In general, we have a strict policy of prophylaxis. It's not that, various specialties like gastro, neuro, cardiac. For example, pediatric cardiac surgery, we use only 3 doses of cefuroxime and stop it.
Yes.
Gastro people use cefuroxime, they repeat it every 4 hours till the end of surgery, and 1 more dose is given.
Right.
Neuro people use again cefuroxime for 3 doses. But there is a tendency to break the rules. At the drop of a hat, you change the antibiotic to higher.
The thing that worries me is that then the next question is, what's your cefuroxime resistance rate amongst community E. coli? Probably the largest single important organism. And I guess it's 70 or 80%, is it not?
It's about 85. He's the best person to answer that question.
Yeah. I think we bring in our own bacteriologist.
Yes.
I think he can answer this.
I am an administrator and try to block as much as possible the high-end antibiotic which has been used. But we have this policy, and it's basically cefazolime and cefuroxime, single dose less than 4 hours, but it, as Dr. SGN has said, that it often gets violated. But the resistance to cefuroxime is close to 70%.
Yeah. So 70% of your patients, you might as well give them sterile water, actually. It's a thought, isn't it? But you could argue for critically, a high-risk patient coming to surgery. Someone with an appendicitis, it probably doesn't matter whether you give them antibiotics. When you give them metronidazole, it probably doesn't matter. But if I was having a colectomy and I'd lived in India for, say, 6 months, I would want a single dose of a carbapenem, actually. I know that's off license and everything else, but actually, because I want some effective prophylaxis. And giving it for just 1 dose over surgery shouldn't select resistance. Shouldn't. But it's an interesting thought. Because that's the thing that keeps me awake at night, is when actually our gentamicin resistance rates get higher. What are we going to use for prophylaxis, effective prophylaxis?
I just have a doubt. When you talk about prophylactic antibiotics, what are actually trying to avoid? We're just trying to avoid some contamination.
You must remember, and the reason the Scottish Guideline Network advice is so strong, and the studies that have shown it, is that all you are doing with prophylaxis in surgery, large bowel surgery, what we're mainly talking about here, is that at the time of surgery, if a few organisms get spilt into the wound and get incorporated into the clot, you're going to kill them when they're very small numbers. That's it. Once you finish surgery, all the wounds have clotted, you've sutured everything up, don't give any more antibiotics. If you give antibiotics, you give antibiotics for 24 hours, 48 hours, 5 days. All you're doing, you're not improving the patient's outcome at all. In fact, you're making the patient's outcome worse, because you're now driving their gut flora and their colonizing flora to resistance to that agent. What are the resistant organisms going to be? Well, they may be Pseudomonas, they may be ESBLs, they might be Acinetobacter. So we ban any prophylactic use of antibiotics, particularly if anybody comes to ITU who's had extended prophylaxis, and I'm pleased to say in the last year when we did an audit, that was effectively 0, then we would stop their antibiotics. We only use antibiotics if we think there is an infection there.
That's a difficult part for us, stopping at 1 dose.
Yeah, that's where your secret lies. But the reason, if you think about why is the reason why your surgeons don't want to do that, it's rather like the birth control situation in populations with large populations. Why do people historically in India and China have large families? Because they're worried that they've got such a high infant mortality that they're going to have no one to look after them in their old age. Why are your surgeons hanging on to your antibiotics? Probably because they're thinking, well, if I keep the prophylaxis going, then the patient won't get an infection. But you're using an antibiotic which 70% of patients are probably going to get an infection. Whereas if you use single dose, highly effective prophylaxis, I would argue you do the patient a lot better service. It's a point of view. It's easy for me to make suggestions. I'm not working here.
There are different guidelines with different societies. There is one guideline which is there by CDC. There is another guideline by Cardiovascular Thoracic Society. And that's how they keep differing the kind of antibiotic used and the duration also.
We've even persuaded our cardiothoracic surgeons and our vascular surgeons to use single-dose prophylaxis. And we audited the process. We audited their wound infections and their complication rates for 6 months before and 6 months after. And actually they had less infections in the 6 months after. I suspect because we weren't colonising patients. Because what had happened was, as you know happens, surgeons said, well, this operation has been very difficult. Keep the antibiotics going for 5 days or whatever. And all you're doing there is are you using an antibiotic that's suitable for treating a primary infection? No. Are you using an antibiotic which is suitable, you're using an antibiotic suitable for prophylaxis, for treatment? That's wrong. If they develop an infection subsequently following surgery, you need to use a different agent. That's a cardinal rule of prophylaxis. And you need to target it as to what's causing the infection. But that's it. It's just a point of view. It's easy for me to drop in for a few days and make statements and go away again. But I think the thing is think about it, really, what you're doing and why you're doing it. That's what we did about 2 or 3 years ago. We realised we were doing it wrong.